allows me to introduce our distinguished guest, Dr. Mohamed S, Zaghloul, a dear friend, senior professor of radiation oncology, emeritus actually in the NCI, and he is the head of radiation oncology department at the Children's Cancer Hospital. I thank him in person for giving me the opportunity to be with us in this short notice. I know I'm apologizing for that. He will give us overlook of the IMRT in breast cancer. Please, sir.
First of all, I would like to thank Dr. Khaled for his kind invitation and for the very nice introduction. That I have only one thing against, that I'm not a guest.
Okay, sorry.
Yeah, I am one of you, and as you are one of us. We are going to speak about the IMRT in breast cancer. First of all, we have to realize that the radiation therapy for the breast is give an excellent local control with the 95% at the 5 years, and with a standard dose of 50 gray plus or minus the boost to the tumor site. So there is no need for dose escalation, but in the, as mentioned by Alphonse, my dear friend, there is a lot of organ interest. The lung, heart, not only the left, as he just mentioned, but also the right side, and even the skin, and we need to have a good cosmetic outcome. So the standard radiotherapy is, for now, is the 3D conformal radiotherapy, and this is the constraints put by the Memorial Sloan Kettering, which we are following, that the BTV must not exceed, the dose must not exceed the 110, while the absolute lung must not exceed 30%, the V20 should not exceed 30%. The mean dose to the absolute lung will be not more than 22 gray, and the heart, the V25 must not exceed the 25%, and the mean dose, and we can add the coronary as well. So what we are using in our department in Children's Cancer Hospital mainly are the field and feed, in order to get the more or less high conformity to the target. And we consider this field and feed as a forward IMRT? I believe yes. So usually we use the field. It is a forward IMRT, so it is a CT plan. 75 to 85% of the dose is given by the open fields. Here, this is the extreme of the 8 extra segments, what usually we use from 2 till 5 extra segments, with the minimal segments to be size of 9 centimeters, and we are trying to get a simple planning objectives. We got many additional benefits for this. We have a less monitor units, so by this we will get a lesser scatter. The planning time is less, the beam on time is much less, and there is less susceptible to breast deformations. This is a paper showing that the field and field have those homogeneity index of better for those who have the field and field more than that of the the conformal radiotherapy with a p-value, significant p-value. The conformity index is also better and better here than the conformal with the, but not of significant value. So, so that is the, to go to the IMRT, the usual type of IMRT. So that's, you can see the distribution here. This is for the conformal, and here the homogeneity is more. So this is the IMRT gives conformity. For the IMRT, we have to have optimization as it's used to achieve a dose uniformity. Less than 15% of the breast volume should receive more than more than 105%, while less than 2% of the breast volume should receive more than 110, and maximum 10% of one lung can exceed 30%. This is the optimizations for the inverse planning. We do it. This is the usual TPS for IMRT with the putting all the constraints and then the putting the optimizations. And so we have to have the intensity map of the which is this intensity map here. We can have this less dose to the lung. And the most important thing is to do a check for the dose. So that is a verification for each patient using either the 2D array or other similar machines or equipment in order to be sure that you have a good contribution and good fluency, and the dose to each point is actual and there is no defect. So after that, the treatment is done, and the treatment time is not much increased compared to the conventional technique. And but here we have to have the electronic portal image, or CBCT, the cone beam CT, to be sure that you are hitting the same target, and you you have a setup verification, and you deal with the uncertainty with correction of the position of the patients. Here, this is a paper talking about the toxicity, both the acute and late toxicity, comparing the IMRT with the conformal radiotherapy. And then you can see that the IMRT gets most of the dermatitis is better for the IMRT, the breast edema is better, and the hyperpigmentation is better for the IMRT. While in the chronic grade, more than grade 2, equals to more than grade 2, the hyperpigmentation is also about to be significant. The breast edema is much improved with the IMRT. The fat necrosis is 0 here, but it's 1 in the wedges, which that's an extreme, the fat necrosis. The induration is also, although not significant, but it is much less for the IMRT. And after all, the good and excellent cosmesis is more or less is the same in both IMRT and conformal. And this is another manuscript showing that the skin telangiectasia is much less in the IMRT than the conformal, and the grades even are much better for the IMRT than that of the conformal radiotherapy. And so the cosmesis is here is better for the IMRT, though it's not statistically significant. It is statistically significant in univariate analysis, but with the multivariate analysis, it is not significant. The Canadian phase 3 multicentric trial showed that the 3D with wedges versus versus IMRT reduced the acute effect, so that's another one. And the odd ratio for the IMRT is better with the IMRT, with the p-value better either in the breast size with the different breast sizes. The Royal Marsden in England is also showing the same results with the shows the reduced late effects with the change in the breast appearance decreased from 58% till 40% for the IMRT, and this reduction occurs in different points of the breast itself. So it shows very obviously that the IMRT shows a better cosmesis. And so those volume comparison for the IMRT with the 3D conformal radiotherapy, we can see that most of the results here, it's better D2, so the coverage is much better. It's not much better, it is better, but it's slightly better. The right lung 30 compared to 45, and also the LAD is not done in this. Brachial plexus is the same, but here the heart, the mean heart is for the IMRT is higher than that in the conformal radiotherapy, and the contralateral lung mean dose is higher for the IMRT than that of the that of the conformal radiotherapy. Another study showing that the IMRT plans shows improved dose homogeneity and clinically associated with reduced incidence of the moist desquamation for this. And this is the that's here to show that we have to do skin to exclude the skin in order to get a better shape of the DVH. But yeah, the actual dose is the same. So the dosimetric evaluations for the IMRT, here the coverage more or less the same with a better homogeneity of the IMRT, but here the heart, the dose is, although this is the IMRT having a high dose, and then it decreased by when you go to the higher dose. Lower dose, the IMRT is higher, while the higher dose, the conformal is the higher one. And it's the same for the total lung. This paper showed that the coverage of the axilla for the level 1 is much better for the conformal radiotherapy than that for the IMRT. The axilla level 2, this is level 1, this is level 2, this is the same, and level 3 even is the same. The IMRT have very minimal dose to the level 3, while the conformal is higher. And so the total axilla is, again, the conformal have more coverage to the total axilla than the IMRT. So what we are doing in CCHE, the Children's Cancer Hospital, usually we treat with the field and field. And so we consider this as the 3D conformal radiotherapy rather than saying that it's forward IMRT. And we did a study, a dosimetric study, comparing the conformal radiotherapy with the IMRT using two open fields, medial and lateral tangential, with the seven fields. Here is 3 from this side and 4 from the other side. So this is the DBH for our study, and we showed that all the D1, the D1 grade, the D5 and D95 are higher for the 7 fields IMRT rather than the 2 fields. But we have the dose to the V107, so the higher is more in the 7 fields. So we get a better coverage, but we get also a higher dose, more than what is recommended. Again, this is the, if we go to the ipsilateral lung, we will have the lung for the higher dose less, but for the lower dose it is more. So that is applied for the ipsilateral lung, the contralateral lung, as well as the contralateral breast. So this is to show that comparing the 7 fields or multiple fields with the 2 open fields and different, this is our study, and this difference, and it is the same. The 7 fields have more coverage to the tumor, but it gives higher doses of the higher low doses to the normal tissue or the organ at risk. So we will go now to the VMAT. This is a paper evaluating the comparison between the conformal IMRT and the VMAT, and it shows that at the lower dose, here this is the lower dose for the normal tissue. The conformal radiotherapy is much less. The VMAT is a little bit higher than the IMRT, and it goes the same until it goes to the high dose. The high dose is more or less here at 20. It is the same, V20 is the same for the 3, and comes the more higher dose. The conformal radiotherapy has more doses to the normal tissue than the IMRT or VMAT. This is another study with the VMAT using the Brown position, and it shows the same again. That's the D mean is the same. The D max is more or less the same, but the homogeneity index is better for the Vmax, while the conformality index is also better for the Vmax. But again, if you go to the normal tissue, you will get the lung for the IMRT. This is a little bit higher for the VMAT rather than the IMRT. In the high dose and sorry, for the low dose rather than the high dose, because this is drawn the reverse. So what about the prone breast radiation? Prone breast radiation minimizes the radiation to the heart and lung by utilizing gravity effect on the mobile breast and specified beam directions with the 2 tangent fields. before inverse planning process is mandatory to avoid the increase in the integral dose of the for the body of the patients, and bring dose intensity pattern to field edges to account for the minimal edema throughout the treatment. And this is the custom-made bronze breast position, bronze breast applicators. And here there is the Orfit invented this all-in-one in which you can have the breast be done here in a prone position. And this is the distribution for the, you got two fields, two tangential fields, so the heart is away or a little bit, but again in the left side where the heart is more important is not that much, because it's in the right side it is more protecting the heart than in the left. Again, if you use a broad position, the IMRT is more homogeneous than the conformal radiotherapy. And this is the in the sagittal view. And Alfonso spoke a lot about the coronary artery dose, which is really an importance. And here, this is the Sarah Derby that he mentions too many. She have the, and this was discussed very beautifully by my colleague and friend Alphonse. And here, this is the dose, the coronary dose for the, this is the standard. More, if you use IMRT, it is less. So another way to decrease the dose to the heart is the active breathing control, like mentioned again by, this is the using the APC, while here there is voluntary breath hold by the, this is a breath hold, and this is the 3D surface image guided breath hold. Here, this is a free breathing, so the heart is shooted. Here, if we have breath hold, and this is done by the 3D central, and so you can have a good putting the heart away from the beams. And we have this technique in our department, the techniques of also with the APC, and this is the deep respiratory breath holds, and this is applied very successfully in the National Cancer Institute, and it is also to be applied in our department. And here, this is the difference between the mean heart maximum dose is for the without breath hold is 35.5 compared to 11 gray, while this is the mean heart dose. This is the maximum dose, sorry, and the mean heart dose is decreased from 2.5 till less than 1 gray, and this may add to the protection of the heart that is needed. The last point is the integrated boost in the breast. So it's very important to delineate the cavity of the lumpectomy. And I think the best way is asking the surgeon to put 6 clips in the cavity of the lumpectomy, and not to be less than 4. So in order to delineate the cavity in the 3 dimensions very well. Again, if you do the sequential So you will get this dose. The dose will not be confined to the cavity. So if you do it in simultaneous integrated boost, it will be more confined. And if you do it in a IMRT, so it will be more homogeneous and more confined to the breast, to the tumor bed. And the benefit of the SIP is the increased dose homogeneity, and again the decreased number of fractions. We, instead of giving 33 fractions of 2 gray, we can give 28 fractions of 1.8 gray with less than half a gray each day as a boost, and then you will finish the patients within 5.5 weeks instead of 6.5 weeks. The acute toxicity was evaluated, and it is very tolerated with no with better cosmesis. And it also decreased the workload on the LINAC, and so that is important in busy department like that we have here. And again, it reduces the planning workload. So you plan it once, not twice. So this is there is significant reductions of the excessive dose volume. The dose decreased from 129 cc for the sequential to 58 for the SIB in one study, and from 129 till 59. Yeah, so there's 2 studies showing the same. Even 3 studies give the IMRT SIB generally better than the conformal SIB. That is the third study conclusion. The post-mastectomy radiotherapy comparison of the IMRT versus 3D conformal in the post-mastectomy setting, including regional nodes. The target included the chest wall and regional nodes, plus minus the internal mammary nodes. The IMRT plan has increased target homogeneity compared to the 2D, but with increased dose to the critical neighboring organs. To conclude, there is a lot of phase 3 trials demonstrate superiority of the IMRT over standard treatment for acute side effects in the intact breast. But there is modest decrease in the late cardiac and lung toxicity with the IMRT. Improvement in the local control is unlikely since the dose is similar in both techniques, and it is already high control rate. But we have to be very cautious, as imaging of the BTV daily is mandatory and is needed given the tight margin, because we use a tight margin, and daily setup error has to be taken care of. Organ deformations, edema, and target mobility with breathing is very important and needs to be taken in consideration. IMRT improves the BTV coverage. IMRT reduces the organ at risk dose at expenses of the higher integral dose and higher low dose for the organ at risk. Wide field 3D conformal radiotherapy cannot achieve comparable results. Careful selections of suitable cases is recommended, as usually when we are confronted with the patients, we do it with the whatever, either conformal radiotherapy or IMRT, and we will choose the best dose distribution. We are not restricting to IMRT, not to conformal radiotherapy, but we are restricting ourselves to the better dose distribution in with whatever technique to be used. The IMRT has become the standard of care for complex breast cancer cases. And I believe Dr. Torian has just mentioned that it's not, you don't have to be obsessed by one technique, but you have to be doing the better for the patients. And this is our campus. It will be in 2 years from now. This is our hospital, existing hospital, and here this is the prototherapy, where we will get the Proteus one, like the one in Nice, and here is the new radiotherapy. This is the outpatient clinic. This is the new hospital. This is the academy, and thank you very much for your listening.